our work. We get to know each other, either in school or in our practices, and I think it's pretty special, and I'll share some of those things with you. So you got my name. I'm not being paid to be here, other than I'm the registrar, so I guess my salary comes from the college. And there's no other sponsorship of this activity. And the other thing that I think is pretty cool is that this day is entirely sponsored by the college, and you'll get your CE credits. I think there's 4.5 credits. Accredited CE, because you have to have a third of them as accredited nowadays. So for coming. The learning objectives, to look at some of the past challenges that we've had in our practice, to recognize ways in which pharmacy practice is evolving today, some of the changes that have happened, and look at the college's role as a regulator and how that works with the evolving pharmacy landscape. Okay, so the first of these live poll things, not on the screen. I've lost my screen here. Oh, there it is. Oh, there's different screens. Okay. So can you name 3 current college board members? You should at least be able to get your own, and there was a hint, there was one right here before me. So get on to the slide.do and use answer code 125. Do I have to do anything? Oh, there we go. Okay, it looks like we've got most of them out. Bob. I'm not a board member, but anyway, that's great. So let's move on here. Go on. And so this is the current board. So if you're guessing any of these names, you got that right, and many of them are in the room. There's some at the back table there. They're spread throughout the room. So if you have any questions about board activities, please feel free to approach them. Blake Reynolds arranged for us to encourage us to have our meeting outside of Vancouver, and we had board meetings, and we have this celebration here. Unfortunately, he wasn't able to be here today with us, so Anar has stepped in and is serving as our lead for these meetings. And then all the board members that you see there, Mona, Ming, Tara, Frank, Arden, Sorrel, Norm, Chris, Jeremy, and George. So let's go back in time. So there's a Back to the Future thing, and I guess the crowd will know the reference to the movie. And I thought it was interesting because when I looked at the slide, I thought, okay, we're going back to May 30th, 1980, which is sort of the time that I graduated from pharmacy school. But if you look at this picture, I thought, those are Dymo tape labels. Remember those? Yeah, so it's another blast to the past. And we're coming forward to the present time now in 2016, which seems it's a long time ago. So this is the video now. I don't know how do I activate the video here?
Yeah, just click.
Oh.
Go back.
So what do I click on?
Sorry, I don't think that thing works.
Okay.
The College of Pharmacists of British Columbia has been protecting the public through pharmacy regulation for 125 years. We started in 1891 as the Pharmaceutical Association of BC and were founded by Thomas Morrison Henderson. In 1967, a separate pharmacy advocacy body was created, and we continued to regulate pharmacy as the College. In 1974, BC's PharmaCare program was introduced, which was the first time a publicly administered drug plan was available in BC. In the late 1980s and early 90s, College Registrar Norm Thomas worked with government to establish PharmaNet, a first-of-its-kind pharmacy system that links all community pharmacies in BC through a central database. PharmaNet allows pharmacists to review a patient's complete medication history before dispensing medication. Pharmacists check your prescription in PharmaNet for drug allergies and harmful drug interactions, keeping you safe. In 2009, the college transitioned to a brand new legislation that governs all healthcare professions in BC. The Health Professions Act makes sure all healthcare professions operate under a common legislative framework. In that same year, we established a professional practice policy that allows pharmacists to renew your prescriptions or make any therapeutic adjustments or substitutions. To support better patient health, pharmacists' scope of practice was expanded to include flu vaccines, and we introduced an immunization certification in the fall of 2009. Over 3,700 pharmacists and pharmacy students are certified to administer vaccines in BC. In 2010, we welcomed pharmacy technicians to the college. They perform technical functions in the pharmacy so that pharmacists can focus more on clinical care. Today, we regulate pharmacists and pharmacy technicians working at pharmacies across BC. No matter how fast the times change, we are committed to ensuring all British Columbians receive safe and effective pharmacy care. The College of Pharmacists of British Columbia, providing better health through excellence in pharmacy.
That was amazing how much they can fit into such a short slide presentation, but I think Gillian Vrooman and her staff did a wonderful job of pulling that together. So, do you remember? What year was the college founded?
Nobody knows.
44, 49 votes? 52? So when does there it is. No? Should I wait?
Maybe nobody knows.
Nobody knows? Did anybody put in a number? There's the votes are in there at 70, 74. Okay. Should I just move on, Gillian, or?
Yeah.
Okay. So it was 1891. I think everybody probably got that, hopefully got that right. It was many, many years ago. So I'm going to move on. So there's lots of changes that have occurred in the profession. And so I'm just going to go through some of those. And the first of those is changes in education. So back in my day, and Parmendra Chooch was with me in this class of 1980, we had a graduating class of 86 students, and we got to know each other pretty well. I looked a lot different then. I had black hair, and up until recently I had a beard here too. But yeah, I think I was quite a bit younger in those days. And you know, the education program has switched an awful lot, and I graduated with a bachelor's degree in pharmacy. I did a hospital pharmacy residency, and that's actually served us very well. The residency program, as I'll allude to later, has been a hallmark. Then in those days, remember, and folks may not know this, but there didn't used to be a PharmD program in Canada. Those folks who did their PharmDs went to the US in order to get that advanced credential on top of their bachelor's degree. And it was a long time before Canada established their own PharmD program, but then we did. And people got advanced credentials working in specialty situations, many times in the hospital, oftentimes in other practice environments. Some of them went on then to do fellowships, specialty fellowships, so post-PharmD fellowships in areas of advanced pharmacotherapeutics and in the various clinical areas. So lots of educational developments over the years, and now we've just started our first entry-level PharmD program. So it's exciting that we're starting on this path where pharmacists throughout the country are converting over to doctorate degrees through the entry-level PharmD, and I'm sure this will continue on with more postgraduate training coming on top of that. So lots of changes on the education that have happened and will happen in the near future. Folks in the room from BC will remember this is the old Cunningham building. I think it was George Torrance Cunningham. Derek, is that right? Something like that. Yeah, George T. Cunningham, the Cunningham drugstores. And that was, I think, one of the reasons that pharmacy became a faculty relatively early, is that there was a benefactor who provided the resources for that building that we all got to know oh so well. And then now we've got this new building, which is incredible facility. If you've ever had the opportunity to go out there, it's beautiful. It's an architectural dream. It's a great place for housing the faculty now. It's much more able to provide the necessary facilities for contemporary teaching pharmacy. And there's been lots of changes in the college. Over the time, our office has changed locations many times. We've been downtown Vancouver. We're sort of just off downtown now in Vancouver. We used to have inspections. We had practice site reviews. We've got various consultations and such, and we have the practice review program is alive and well. But we look now, when we do these reviews, not just at the pharmacies, but the pharmacists and pharmacy technicians as well. In the old days, we had, I think we used to call it the competency assessment or something like that. At the knowledge assessment, an exam that we had to do on a regular basis to assess whether we knew what we were doing. And that went on for many years, and up until recently, when we switched over to a more contemporary model of actually looking at what you do in your practices. We had, for many years, our governing body was the college council. And we had a president and vice president of the council. And with the new HPA, we've come around now to boards. And so it gets a little confusing sometimes when we have these various ways of remembering and commemorating people who have served as, now it's presidents and board chairs and councils and boards. So we've had a lot of changes in that regard. Government appointees. When I was first on the council of the day in the 80s, we had one government appointee, Doug Mowat, if folks will remember. It was sort of a new thing to have a non-pharmacist, non-pharmacy professional as a member of the board, and Doug was great, and he certainly brought a different perspective to the table, and now that's considered to be a normal part and an important part of governance, is to have not only the folks from within the self-governing profession, but also with representatives from the public who are appointed by government. And of course, most recently, we've had pharmacy technicians come into the college and welcome them as an important part of the profession. And really, the coming into the college, I think, marks that the work that technicians do is extremely important and valuable, and it needs to be regulated. We need to know that technicians are qualified to do the work that they do, and to have them as part of the college. And certainly for those of us who have trained in pharmacy in British Columbia, we know that for much of our training, experienced technicians were teaching us how to work in the drug distribution system. So those are our new digs. I think probably many of you have seen them. We were fortunate back in the video we talked about Norm Thomas, and this was another one of Norm's legacies, was to initiate buying of a building. So we back in the 90s or late 80s, we identified that we were spending an awful lot of money on rent. I think in those days we were spending $100,000 a year on renting a space in downtown Vancouver, and if we could find a place of our own, that would be wonderful. So we looked around, we looked at sort of the strata councils or strata arrangements in Vancouver and such, and we found that the College of Dental Surgeons was also looking. And so we actually went in, and we now have a joint venture with the College of Dental Surgeons that's been really great to co-own that building. So they own 70% and we own 30% of the building. And as a result, our overhead is much lower than it would be otherwise, because I don't know how long it took. It took 8 or 9 years before we paid off our debt from the building. So essentially since this century, we've been rent-free for the most part at the college. So that's helps to reduce our operating. If you look at the changes in BC, the number of hospital and community pharmacists and technicians, things have changed. And the distribution of folks in the community side and the hospital side has also changed. But we've got a whole lot more pharmacists and pharmacy technicians working in this province. And I think it sort of reflects, I'll show in some later slides, the therapeutic explosion that we've seen in pharmaceuticals. So in the time, we've had 20 registrars and 97 presidents. I saw Erica Gregory's right here, is another past president. Welcome, Erica. Thanks for coming. And I saw on the list Don Hamilton. I don't know if Don actually made it up. Don, are you here? No, maybe not. Well, we've got some more pictures of Don coming up later, but John was also another past president of the college. So these are photos of plaques that are in the college office that commemorate past councils through the presidents, the board chairs, and the registrars of the day. So pharmacy technicians, as I mentioned, are an important part of our college. We now have 1,385. It's probably a little bit different than this now, but that's a lot of registered technicians, and I think it's a very valuable and important step for the college to have taken. Okay, so the people have changed, and I referred to Don Hamilton, and he's the one on your far left. Peter Jewison is in the middle, and John Hope, who is another past president of the college. So two of those three guys are past presidents. And you know, this part of being in the club, you kind of remember those days when we were young and having, well, we have fun still, but we had a lot of fun in those days. And there's Don, at the other end of the spectrum, is retirement days. So he's retired from Children's Hospital, looking very happy, a little bit older. Peter is esteemed Dean Emeritus of Qatar University in the Middle East. And John Hope is still around. So, you know, we're still around, and I think that the part of the thing about being in a club is that you're in it for life. You know, you have some great memories, some great relationships, and you can see as we travel through time how things have changed. So we've gotten a lot older. We've also seen a lot of practice changes, and my background, I think as many of you will know, is in hospital pharmacy. And in hospital pharmacy, the world has changed completely. I sort of started at the beginning of the big changes in hospital pharmacy in BC. And you know, it used to be that hospitals were all ward stock, that there were very few prescriptions filled in hospitals, and hospital pharmacists didn't do much more than actually buy drugs and put them on the floors in big bottles. And you know, that was just the way things were. And then the big move was over to actually having prescriptions that got checked and filled by pharmacists. And then in British Columbia, we didn't really get into the unit dose thing, but certainly in the rest of Canada, there's a big move to unit dose drug distribution systems. We had a well-established residency program that was a cornerstone moving forward. Pharmacokinetic services were big in the 80s, and certainly my residency was focused in on that therapeutic area. A lot of great stuff, and it's interesting, as time moves on now, kinetics is nothing. It was just a normal part of pharmacy practice, but in those days it was cutting edge. We did bedside rounds, so going around with the full medical team, and reviewing each patient and being really a good collaborative practice environment for pharmacy. We went through various stages of automation and centralized drug distribution systems. And overall, the big thing that changed over the years, and I think has become very well established in the institutional environment, is that we have an integrated clinical team, and pharmacists are considered to be really valuable members of that clinical team. And so you go from complete ward stock systems where the impact of pharmacists was near nothing to being an absolute important and valued member of the team. This is just a photo. Back in the day, the Dublin report changed drug distribution systems in many parts of the country because of some deaths in the hospital for sick children in Toronto. One of our mentors in hospital pharmacy practice, Jim Mann, wrote an editorial about how residencies transformed hospital pharmacy. And they did so for so many reasons in terms of the mentors having to come up to speed, for having great people to do the residencies, and then the projects and the groundbreaking that they could do in new areas of practice. And there was my residency project in the drug measurement or the pharmacokinetic monitoring service at St. Paul's Hospital, which was in its day a pretty big deal thing. Oops. In community, there's been a lot of stuff happen too, and I guess most of my exposure to community pharmacy has been through serving as a president in the 80s and on the college council and various other roles that I've played over time. And you know, I remember we still are the only province to not prohibit tobacco sales in the province from pharmacies. But you know, there's been a ongoing conversation for many times, and you know, we've had votes and various discussions at the council table about tobacco, but it continues to be an issue for some people. We went through a phase with mandatory patient counseling, and if you talk to people like Vern Childs in Ontario, Sarnia, he'll tell you that it was a big deal for pharmacists to even be able to put instructions on labels. He was actually disciplined for putting instructions on a label of a prescription back in the 60s. And time moves on to meet the needs of patients, and so we get we got patient labels are certainly not controversial. Patient counseling is a requirement. And we find that sometimes these things get missed in sort of the busyness of the environment. But in my conversations with practicing community pharmacists, they say every time they have those conversations, they learn something, and it helps to build that therapeutic relationship. Mandatory patient profiles are another thing that came up through the 80s, and I don't know if people remember, but the reason we went to PharmaNet was because we had this mandatory patient profile that was just a real pain. And it was bad because people were handwriting out and putting copies of labels on these cardboard pieces of paper to remember what drugs people were on. And it was hard because people once you stopped the medication, you had to kind of cross that out and figure that wasn't in there. And then you had this really a mess of paper, and people went to more than one drugstore. So you knew that it was never going to be accurate, but we still made people do it. And that was one of the main pushes for Norm Thomas to say, if a pharmacist needs to dispense competently, they have to have a centralized database, a PharmaNet system. So PharmaNet is the result of the work of this college, and I think it's something that we're very proud of. Medication reviews, we've been doing it in recent days, but some people have been doing it for a long time, but I think we've come to the point where these are being done in mainstream, and there's actually compensation systems to provide for that recognition by the provincial pharmacare program. Different changes in scopes of practice, whether it's with immunizations, where the government during a public health emergency wanted to get more people immunizing for the flu, so we responded to that, and now I think doing flu shots is a really big deal, and something that is helped to reinforce the patient care aspects of pharmacy practice. And adaptation, so actually being able to change the prescriptions to meet the needs of the patients is important changes that have happened in community pharmacy practice. So these are some of the headlines that have come through. The ability to renew prescriptions for Minister Abbott provided that opportunity. The injections for vaccines. Different things, and we continue to push forward. There's pharmacies who are doing HIV testing in various pilot programs in Vancouver, and working very closely, obviously, with medicine and collaborating. And it's really a screening program, and where there's a non-negative screen, then immediately the patient would be seen by a physician who can do it more rigorously. And the other things that we've got going with the pharmacist clinic at UBC, and saying that this is a great example of a model that although much of pharmacy is still product oriented, you can have a practice that isn't dependent on the physical product of the drug. Going forward, there's more things on the horizon. We're doing work in pharmacogenomics, and Corey Nislo is spearheading that work at UBC. And it's a really interesting area that I think we're going to see more and more of as we move forward. And our neighbors to the east, Alberta, have prescribing privileges, and they pioneered this, and certainly it's something that this college is having discussions with the provincial government about, and will be moving forward with. So in the last little bit is talking about some of the changes in the drugs, because pharmacy is all about drugs. So going a little bit further back than me, I thought I'd kind of find that the first CPS. So I went out to CPHA in Ottawa a few years ago, and said, can I take a picture of the first CPS? So that's it. And it was 491 pages, and the molecules that we were dealing with were fairly simple. And there's an example of one of them. I think that's ibuprofen, one of the NSAIDs. So I took some photos of some of the drugs that were included, but there are things like the dermatologicals. They were very big, and I know that talking to Aaron Sahota that they're coming back. Dermatologicals are still an area of important practice for pharmacy. If you look at this, and I know you can't read it, but the drugs that we were dealing with were what we would call fairly straightforward now. So there's like ampicillin was a big deal. There's sort of vitamin drops, but that was sort of the lay of the land in those early days. Real therapeutic drugs like chlorpromazine these were the ads in the book at the time. But if you notice, this is the king of neuroleptics. Like that's supposed to help you make a therapeutic choice. But if you look at it, it's kind of subtle. But that king, if folks know cards, it's the suicide king. So he's actually got a sword through his head, which is a bit morbid, but interesting ad. A big therapeutic drug this is a thiazide diuretic, and I mean, you got to think, in the 60s, whoa, what were the drugs? I mean, when I've given presentations and lectures to pharmacy and medical students, I said, even when I came through in the 80s, there weren't that many drugs compared to what we have now. In fact, if you look at, I just kind of sat around and thought, well, okay, what are the new drug classes since I graduated? And these are, ACE inhibitors, I'm old, so ACE inhibitors are new since I graduated. So we didn't hear about any of these things in school. Even like the statins and the atypicals, the antiretrovirals are all new. And these are all classes of drugs that were not around when I graduated from pharmacy school. And in fact, if you look, I looked at the Pharmacare Trends report out of the provincial government, and all but one of the top drugs, of their top 10 drugs, based on from Pharmacare reimbursement in 14-15, they were unheard of when I graduated from pharmacy school. So it really underscores the need for continuing education and keeping up on things, because the worst thing is, I hate it when I see a name of a drug that I've never heard of and I have no idea what that's for. I think the only one here that was around when I graduated was methadone. But other than that, none of these were available. Costs have increased, and you've certainly seen that. When I started at St. Paul's Hospital in the 80s, we used to track the drug costs and bill back to the nursing units when a drug cost more than 25 cents. And that was considered expensive. I was like, whoa, it's like a 25-cent pill, that's huge. And then there's these points in time where all of a sudden we broke through, and so we got the sumatriptan and ondansetron. They were like $15 a dose, and everybody got, whoa, $15 a dose, who's going to pay that? But we did. And I think that's part of the economics of this thing, is as long as the markets pay for these things, that they'll continue to rise in price. So streptokinase, one of the first clot buster, is $300 a dose. Alteplase, the second gen was at $2,000. I took a slide out here, but when I was chair of the provincial buying group, I wrote a note because the price of these drugs went up incredibly. And yet, because it's a captured market and we're going to buy it, we had no recourse. And then you just get into the craziness of today, where some of these very, very rare drugs for rare diseases are up into the $900,000 for galsulfase. That's for one patient for 1 year. So you think these are no longer being priced for individuals. These are being priced for large insurance programs and governments. And it's a reality of the day. And some of the challenges, the headline there is Trey Purcell, and out of the Vancouver Sun. And this was a young man who had one of these rare diseases that needed one of these drugs. And back to the changes since that first CPS. Now we've gone online. There still is a paper version. I think many of you still have those, but the online version, we've gone in from molecules that are straightforward, like this one, to drugs like the one that's portrayed there, which is infliximab. So a completely different game in drugs. And right now the CPS has more than 2,000 product monographs for various things. Life is very different as a pharmacist now with the drugs that we have to deal with. So back to the future, the last bit of it is we've changed our emblem, the crest. If you look back at my college certificate, there's this very regal, fine line etching of the crest. And over time it changed, and actually I was involved on the council of the day when we said we had to clean this up because it was being photocopied over and over and it was getting kind of blurry. So we sort of issued it in bit modern time. Those were the burgundy days of the College of Pharmacists, if those would remember that. And then we went away from the crest altogether, and we went to the blue and green squares, if people remember that. And then in recent times, since I've come back as registrar, we're back to the future. We're back to something that's very much more akin to the original one, with the crest for the College of Pharmacists. So with that, I'm out of time. So thank you very much.